Erythema Annulare Centrifugum, EAC. Good day everyone. Today, we are diving deep into Erythema Annulare Centrifugum, EAC. This dermatological condition is notable not only for its distinctive clinical presentation but also for the wealth of information it offers about potential underlying health issues. Let us explore the critical question: why understanding EAC matters? Why understanding EAC matters? EAC is a condition that demands our attention for several reasons. Indicative of underlying conditions, EAC can be associated with infections, bacterial, fungal, viral, chronic diseases such as diabetes and thyroid disorders, and even malignancies, though less commonly. Recognizing EAC prompts further investigation into these potential underlying causes. Early detection and management of such conditions are crucial. Diagnostic challenge: EAC shares clinical features with other dermatoses such as psoriasis, tinea corporis, and granuloma annulare. Proper identification is essential to avoid misdiagnosis and the ineffective treatments that may follow. Impact on quality of life: though not typically life-threatening, the chronic, relapsing nature of EAC can significantly affect a patient's well-being. Lesions that are visible or pruritic can be distressing. Effective management reduces flare-ups and improves quality of life. Therapeutic implications: understanding the pathophysiology and triggers of EAC aids in tailored therapy. For example, if EAC stems from a drug reaction, discontinuing the offending drug may resolve the condition. Similarly, addressing infections or other triggers can lead to resolution. What can I do with this knowledge? So, what can you do with this knowledge? Let's break it down. Clinical practice: for healthcare providers, especially dermatologists, recognizing and understanding EAC improves diagnostic accuracy and patient care. Personalized treatment plans and patient education become possible. Research and education: knowledge about EAC fuels research into its causes, treatments, and systemic links. For medical professionals, understanding EAC broadens diagnostic skills and clinical acumen. Patient education: educating patients about EAC, its signs, triggers, and management strategies, empowers them to manage their condition proactively, recognize flare-ups, and adhere to treatments. Public health perspective: EAC highlights the connections between dermatology and systemic health. Integrative medical care, where dermatological assessments inform holistic health evaluations, is the way forward. Clinical scenarios: to solidify our understanding, let's examine 3 scenarios. Scenario 1: background. A 45-year-old woman presents with erythematous, annular lesions spreading on her torso and upper limbs. She started a statin 2 months ago. Clinical approach: the dermatologist notes the correlation with statin use, orders a biopsy and labs, and confirms EAC. The statin is discontinued, and corticosteroids are prescribed. Outcome: lesions resolve after discontinuation of the statin. Key point: drug-induced EAC highlights the importance of a detailed medication history. Scenario 2: background. A 34-year-old man with ring-shaped lesions reports a recent camping trip with insect bites and a mild fever. Clinical approach: tests show elevated ESR and EBV infection. A biopsy confirms EAC. The viral trigger is managed with supportive care and steroids. Outcome: lesions resolve as the infection clears. Key point: infections are common triggers, and history is invaluable. Scenario 3: background. A 47-year-old woman has non-itchy annular lesions, joint pain, and a history of hypothyroidism. Clinical approach: autoimmune screening reveals rheumatoid arthritis. The patient is referred to a rheumatologist. Outcome: interdisciplinary management addresses both the skin condition and systemic disease. Key point: EAC often coexists with autoimmune conditions. Mental models that not only sharpen our understanding but also enhance how we approach this intriguing dermatological condition. Let's make this practical, logical, and engaging. Mental models for understanding EAC: input process output model. Input: think of the factors triggering EAC. These could be infections, medications, systemic diseases, or even environmental influences. Process: the body's immune system responds to these triggers, leading to inflammation and ultimately, the manifestation of skin lesions. Output: the clinical presentation of EAC. Those classic annular, erythematous lesions, along with potential complications or, with proper management, resolution. This model simplifies a complex condition into actionable stages, making diagnosis and treatment more straightforward. Systems thinking: don't view EAC as merely isolated skin lesions. Instead, consider it an indicator of systemic health issues. For example, how do the immune, endocrine, and integumentary systems interact in EAC? Systems thinking encourages us to address the patient holistically, looking for broader connections and underlying dysfunctions. Root cause analysis: apply the 5 whys approach to drill down into the why behind the condition. Let's say a patient develops EAC due to a medication. Why was the medication prescribed? Were there alternatives? Why did this immune response occur? This technique pushes us to uncover deeper, often overlooked, contributors to EAC. Factors triggering EAC. Understanding the triggers of EAC is critical. Let's break them down. Infectious agents. EAC is often triggered by infections, where the immune response spills over into the skin. The types of infections associated with EAC include bacterial infections. Streptococcus species are a common culprit. These bacteria can cause immune complex deposition in the skin, leading to characteristic lesions. Viral infections. Hepatitis B, herpes simplex virus, and Epstein-Barr virus are frequent triggers. These viruses activate widespread immune responses, which sometimes manifest as EAC. Fungal infections, pathogens causing tinea infections, or ringworm, can occasionally mimic or trigger EAC. Parasitic infections. Though rare, some parasitic infections have been reported to cause EAC-like eruptions, underscoring the immune-mediated nature of the condition. Medications. Drug-induced EAC occurs when a medication sparks an immune reaction. Examples include antibiotics. Penicillin and sulfonamides are known for causing hypersensitivity reactions, including EAC. Diuretics. Hydrochlorothiazide, a commonly used diuretic, has been implicated in EAC cases. Anticonvulsants. Medications like phenytoin have also been associated with EAC development. Biologicals and chemotherapeutics. Rare instances of EAC have been observed following treatment with biological agents or chemotherapy drugs that significantly modulate the immune system. Underlying systemic diseases. EAC often points to deeper systemic issues. Consider these associations. Thyroid disorders. Both hypothyroidism and hyperthyroidism can disrupt immune regulation and are linked to EAC. Autoimmune diseases. Lupus and rheumatoid arthritis, conditions characterized by chronic immune dysregulation, are known triggers. Cancer. In rare cases, EAC presents as a paraneoplastic syndrome, particularly with hematological malignancies like lymphoma. Diabetes. This chronic condition alters immune responses and is sometimes noted alongside EAC. EAC can both reveal and be exacerbated by systemic conditions that involve immune dysregulation or chronic inflammation. Miscellaneous factors. Finally, let's not overlook other possible triggers. Physical triggers. Chronic skin irritation or trauma has occasionally been linked to the onset of EAC lesions. Dietary factors. While less common, certain foods or additives may act as triggers, especially in individuals with specific food sensitivities or allergies. Environmental factors. Exposure to environmental allergens or irritants can sometimes precipitate EAC. These triggers remind us to consider the patient's environment and lifestyle when evaluating their condition. Immunological response in Erythema Annulare Centrifugum, EAC. Step 1. Trigger exposure. The journey begins with exposure to a trigger, be it an infectious agent, a medication, or an underlying systemic disease. Each of these pathways activates the immune system in unique ways. Infections. Pathogens such as bacteria, viruses, or fungi introduce foreign antigens into the body. The immune system identifies these antigens as non-self and launches a defensive immune response. Medications. Certain drugs act as haptens, small molecules that, when binding to larger proteins in the skin, create a new antigenic structure. The immune system then perceives this structure as foreign, triggering a reaction. Autoimmune and systemic diseases. These conditions disrupt self-tolerance, leading the immune system to mistakenly target the body's own antigens, including those in the skin. Step 2. Immune activation. Once the immune system detects a trigger, a cascade of immune responses unfolds. Antigen presentation. Specialized cells, such as dendritic cells, capture and present antigens from the trigger to T cells. This process is crucial for initiating an adaptive immune response. T cell activation. T cells, now activated, proliferate and differentiate into subtypes. Helper T cells recruit additional immune cells and release cytokines, amplifying the immune response. Step 3. Inflammatory response. The cytokines released by activated T cells are instrumental in driving inflammation, cytokine release. Cytokines like interleukin-1, IL-1, tumor necrosis factor alpha, TNF-alpha, and interleukin-6, IL-6, increase blood vessel permeability, allowing immune cells to infiltrate the affected area. Infiltration by immune cells, neutrophils, eosinophils, and monocytes migrate to the site. These cells may directly damage tissues or further enhance inflammation. Step 4. Immune complex formation and complement activation. In some cases, immune complexes form and deposit in dermal blood vessels, exacerbating the response. Complement activation. This process generates molecules like C3a and C5a, which increase inflammation and recruit more immune cells. Vasodilation and edema. Enhanced vascular permeability results in redness, erythema, and swelling, edema, hallmark features of EAC. Perivascular infiltration. Lymphocytes gather around dermal blood vessels, creating the perivascular cuffing, observed in histopathology. Step 5. Skin lesion formation. The culmination of these processes manifests as the characteristic lesions of EAC. Step 6. Resolution or chronicity. The final stage depends on the immune response and the management of the trigger. Resolution, if the trigger is eliminated. Be it an infection, drug, or systemic condition, the lesions may resolve spontaneously without scarring. Temporary pigmentation changes, hyperpigmentation or hypopigmentation, may occur where the lesions were present. Chronicity. If the trigger persists, the lesions can recur or become chronic. Such cases require ongoing management, including topical treatments or adjustments to medication and lifestyle. Appearance of lesions. EAC typically presents with annular, ring-shaped, or arc-shaped, erythematous lesions. These lesions gradually expand peripherally, often clearing in the center, resulting in a classic central clearing pattern. Distribution. Lesions frequently occur on the trunk, arms, and legs but generally spare the face, palms, and soles. Symptoms. While most lesions are asymptomatic, some patients experience mild pruritus, itching, potential complications. While EAC is generally benign, complications may arise if triggers are not addressed. Recurrence. The most common complication, often due to unresolved underlying triggers. Secondary infection. Scratching or skin damage can lead to bacterial infections, such as impetigo. Misdiagnosis. Conditions like tinea corporis, psoriasis, or granuloma annulare can mimic EAC, resulting in inappropriate treatments. Psychosocial impact. Recurrence or visible lesions may lead to distress and decreased quality of life. Importance of trigger identification. Effective management hinges on identifying and addressing triggers. For instance, altering medications if drug-induced, treating infections that might perpetuate the condition, managing systemic conditions like diabetes or autoimmune diseases. Immune system interaction. The immune system is the central player in EAC. Here's how it interacts and contributes. Trigger response. The immune system recognizes triggers such as infections, drugs, or allergens as foreign. Antigen-presenting cells, APCs, process these triggers and stimulate T cells and B cells, initiating the immune response. Inflammatory cascade. Activated T cells release cytokines like interleukin-1, IL-1, interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha. These cytokines promote inflammation and recruit additional immune cells to the site, leading to the characteristic lesions of EAC. Immune complexes and complement activation. In some cases, immune complexes deposit in dermal blood vessels, activating the complement system. The complement system releases anaphylatoxins C3a, C5a, which increase blood vessel permeability and attract more inflammatory cells, amplifying the reaction. Endocrine system interaction. The endocrine system influences the immune response and skin health, playing a key role in EAC. Hormonal influence. Cortisol. Has anti-inflammatory effects, but chronic dysregulation can impact immune function. Thyroid. Hormones, both hypothyroidism and hyperthyroidism, can alter immune responses, potentially triggering EAC. Stress response. Chronic stress disrupts the hypothalamic pituitary adrenal (HPA) axis, enhancing susceptibility to inflammatory conditions like EAC. Integumentary system interaction. The skin, as the site of EAC manifestations, interacts closely with these systems. Barrier function. The skin acts as a protective barrier. Damage or dryness can allow allergens or pathogens to penetrate, triggering EAC. Local immune response. Langerhans cells and dermal macrophages, resident immune cells in the skin, activate in response to triggers, contributing to inflammation. Skin microenvironment. Factors such as hydration, temperature, and external irritants influence skin cell and immune cell function, impacting EAC lesion development. Systems interplay in EAC manifestation. EAC results from intricate interactions among the immune, endocrine, and integumentary systems. Immune-endocrine interaction. Hormonal imbalances can modify immune responses, influencing the severity and persistence of EAC. Immune-integumentary interaction. Immune responses localized to the skin create the visible signs of EAC. Endocrine integumentary interaction. Hormonal changes affect skin elasticity, hydration, and barrier function, shaping how the skin responds to inflammatory insults. Flowchart for EAC diagnosis and management. Step 1. Initial patient presentation. Description. Patient presents with erythematous, annular, or arcuate lesions, possibly pruritic. Action. Conduct a detailed history and physical exam, focusing on lesion duration and evolution, e.g., central clearing, scaling, symptoms and recent exposures, medications, infections, allergens, medical and family history of systemic diseases. Step 2. Consider differential diagnosis. Rule out tinea corporis. Use KOH preparation to check for fungal hyphae. Lesions often have more pronounced scaling. Psoriasis. Skin biopsy reveals epidermal thickening and neutrophils, Monroe microabscesses, granuloma annulare. Biopsy shows necrobiotic granulomas with a palisade histiocyte arrangement. Lupus erythematosus. Check ANA and dsDNA serologies. Lesions often scar and may involve the face. Other figure 8 erythemas. Differentiate based on distribution, evolution, and histology. Step 3. Diagnostic tests. Skin biopsy. Ideal from the active edge of a lesion. Histopathology shows perivascular lymphocytic infiltration. Fungal tests. Scrape lesions for KOH analysis to rule out fungal causes. Laboratory tests. Complete blood count, inflammatory markers, ESR, CRP, thyroid function tests, and infection serologies. Step 4. Diagnosis confirmation. Confirm EAC when clinical and histological findings align. Seek a dermatologist's input for unusual presentations. Step 5. Identify possible triggers. Investigate medications, recent infections, or systemic diseases as potential causes. Assess for allergens or environmental factors. Step 6. Develop treatment plan. Topical treatments. High-potency corticosteroids like clobetasol propionate for 2 to 4 weeks. Use sparingly to avoid side effects. Systemic treatments. Prednisone for severe cases, starting at 0.5 to 1 mg/kg/day and tapering based on response. Antihistamines to manage pruritus. Address triggers. Adjust medications or treat infections. Step 7. Patient education and follow-up. Recurrence and chronicity. EAC can recur if triggers are not identified. Inform patients about the potential for chronic episodes. Follow-up visits. Schedule initial follow-up 4 to 6 weeks after treatment initiation, then periodically to monitor for recurrence. Step 8. Long-term management. Monitor recurrent or chronic cases. Educate patients on lifestyle modifications and trigger avoidance to reduce flare-ups. This comprehensive understanding not only equips us to better manage EAC but also enriches our broader medical perspective, blending the microscopic details of immunological responses with the macroscopic view of systemic health. Through this lens, every patient's story with EAC adds a new chapter to our ever-expanding medical knowledge, reminding us of the complexity and interconnectivity of human health. Thank you.